All too often, when someone is labeled as being mentally ill, everything else takes second place to the mental illness. First and foremost, in addition to the mental illness, patients are people. And above all, they are people. And as people, they can become obese, they can develop hypertension, and they can get diabetes, all of which has to be dealt with in an integral and integrated manner.
They are limited to controlling behavior-altering symptoms so that society doesn't feel scared.
The general population believes in myths, but equally so do healthcare professionals. This veil makes the healthcare professional unable to see any other problems that someone might have in addition to mental illness. Many times, we don't look into the other unspoken complaints that, in other patients, we would investigate.
If you are using healthcare services, you believe that you are in the best place possible to be protected and understood. When you experience this type of stigma from the staff, it can hurt so much. The idea persists that people with mental illness are incapable. This idea exists not just in health, but rather throughout the entire healthcare system. Sometimes they are treated as if they are all the same, but in every case we have to be more open to the individual characteristics of each person.
People believe the biggest danger faced by people with mental illness is death by suicide. 60% of people with mental illness die from cardiovascular disease, in other words, common illnesses that affect the general population. One key aspect, which has become known by the name of metabolic syndrome, consists of 4 major risk factors. One is obesity, diabetes, hypertension, and dyslipidemia. When these conditions co-occur, they greatly increase the risk that a person will develop diabetes and therefore a cardiovascular illness. In primary healthcare, we frequently focus on the main symptom, or as in this case, the main illness, that is the serious mental disorder. We often see the serious mental disorder, but we don't see the person. There's probably a common tendency to disbelieve someone with a mental illness when they tell you it hurts, but to believe someone who doesn't have this label when they tell you the same thing.
This is your GP, and this is your local nurse, and they are the ones who have to care for this person. Let them change their own behavior to avoid further illness.
I remember attending Enrique, a patient of 20-something years old. After the consultation, I was overwhelmed because I realized I had mostly addressed the father or the mother and somehow ignored Enrique. I was complaining a lot of back pain, and they told me, look, there's nothing wrong with you. Go to the gym or go out walking. Maybe do some small circular movements with your shoulders. They told me all this, but none of it helped me at all. They didn't look, they didn't touch me, they didn't do anything. And this happened several times until I said to myself, why am I going to keep going if it's for nothing? It's very important to recognize that a primary health care doctor plays a key orchestrating role while being the one who cares for the patient and treats all of the patient's illnesses. When someone arrives in AE showing signs of mental illness, they will probably be sent to a psychiatric examination room even when they are repeatedly complaining of pains in their chest.
Nobody listens when you arrive in A&E. I've experienced arriving at A&E and being left to one side in a corner.
Sometimes patients come back again and again to A&E, and it's like, this is Paco, he's been here 7 times already. Leave him over there on his own. They don't attend to him as if he were another person.
Antonio had been living on the streets for several years and regularly turned up in A&E. He was a known patient in Malaga, and everyone could see he had a hernia. Even though his abdomen was extremely swollen, the general opinion was, with Antonio, what of post-operative care? We'll operate and then he'll be back on the streets. In reality, everybody was thinking this. Finally, when they did operate on him, they operated on him in A&E, which resulted in a level of complications that could have quite possibly been avoided. If they had coordinated more with internal medicine, with psychiatrists, he could have been admitted.
Another question that always causes problems in hospitals is, where do you admit someone who has a mental illness? A person can be mentally ill, but really, if they are having a heart attack, the best thing would be to admit them to a coronary care unit. A patient who has an organic pathology needs to be treated in a place accordingly. Just because someone has a mental health diagnosis as well as a broken leg doesn't mean you send them first to the acute medical unit and then afterwards to the traumatologist. Actually, it should be the other way around.
Juan needed a cataract operation, and prior to the operation was extremely excited about the possibility of being able to see again, as he had minimal visual ability. However, on the day of the operation, the ophthalmologist said he would not operate without a general anesthetic. The doctor wanted a GP's report and a psychiatrist's report in order to operate.
A doctor, on seeing the diagnosis of a patient, said, "Okay, so you have bipolar disorder. How are you coping and how does it affect you?" She told him, "Look, I'm not here because of my bipolar disorder. I'm here because I have a very real back problem. It hurts and I have a problem with my spine." Sometimes, when a patient has spent a couple of days in the appropriate unit for their actual physical illness, they realize that the patient has a mental disorder. And even though the patient is asymptomatic, they are well, the disorder is being controlled by the medication in the majority of cases, and for the simple fact of having been hospitalized at some point, as is necessary when in crisis, they automatically no longer want to admit them into these units.
A 57-year-old service user was admitted with lung cancer. She was very aware of what was happening to her, but the hospital automatically called us for 24-hour care. There hadn't been any altercation, nor was she agitated. She shared a double room with another patient, but they still complained about this due to her mental illness.
Everybody who doesn't lack capacity has capacity. This is something that all too frequently we as professionals forget.
Puri had a partner, and she decided to have a tubal ligation to avoid the risk of pregnancy. She went to the gynecologist, accompanied by her support worker, a non-healthcare professional responsible for some of her care. The doctor immediately addressed the support worker and never talked to Judith, never listened to her, and furthermore, refused to do the operation unless someone came to sign the authorization and produce a paper saying she had capacity. We told him that this did not exist, that she has full capacity, and that we could guarantee it. Furthermore, we told him to listen to her and her reasons why she wanted the operation, but the gynecologist refused.
Firstly, you have to fight against the stigma of pharmaceutical medication, which, often with mental illness, as with physical illness, is absolutely essential. People who need medication have to take it. One persistently unanswered question is on the subject of medication side effects and interactions. It has as much to do with medications prescribed by doctors as those prescribed by other professionals such as psychiatrists. For example, someone with bipolar disorder controlled by lithium who develops high blood pressure must keep their psychiatrist informed about the high blood pressure medication prescribed by the GP. But also, the GP must be aware that the patient is taking lithium. We GPs are specialists in primary health care. From time to time, we have to review medication in order to see the complexity of the interactions and side effects. Let me tell you this, though. We frequently don't have the information at hand in the same way that we would be able to access for other patients.
You see, for example, someone who has gained 15 kilos in weight, even though she enjoyed going to the beach and being active. She approached her psychiatrist and said she couldn't continue to gain this much weight. When she spoke to her psychiatrist or went to the health centre, she was told, "You're not so fat, you're just eating more." Or, "Don't worry, this is just the first 15 days. She couldn't find any way to express her anxiety or the things which were worrying her. In the end, we discovered that she spent 3 months without taking medication and hadn't told anyone.
On one hand, we have the patient and everything concerning them. On the other hand, we have the professionals, the healthcare system, and the type of treatment. Certain patients are more difficult than others, or they ask more questions about what is being done with them, and they often try to convince through harsh negotiation. Then there are the professionals who don't listen to the problems the patients have with their medication. They just don't listen. So here's what we have to do. We have to be clear with the prescriptions. We have to listen to the problems that are created by what we prescribe. And we also have to negotiate with the patients. I believe that self-stigma is one of the biggest problems that people with mental illness face. When we internalize all these images, all of these beliefs in our culture, sometimes they come from our family, sometimes from the media, sometimes from healthcare professionals. I mean, it's enough to live with and enough to endure a mental illness. But with everything else, it means that we don't take care of our own physical health. You have to be very independent with a lot of dedication, very empowered to be critical, so that it doesn't affect you and that you don't believe this self-stigma.
As a family, anxiously waiting for an illness to stabilize, we often don't realize what the problem is until after some time has passed.
When you haven't really started the recovery process of all this, it's like a stone slab that weighs you down because you think to yourself, what do I matter? I don't matter at all. I'm only a sick person, or in this case, mentally ill. My life doesn't mean a thing. I mean, why? Why have a healthy sexuality? Why live a balanced life? Why do exercise? Why consider reproduction? Why consider children or parenthood? For a long time, many professionals thought that people with mental illness would not be able to promote their physical health due to being incapacitated, due to being damaged. But these are absolute myths with no basis in reality. This culture is based on, well, it focuses more on the illness rather than promoting health. Today, we are speaking about recovery in mental health. This means that we believe people can get better. People have the power to take control of their own lives. If we consider physical health, people can also take care of their own physical health. Conduct yourself well and you will start to feel better. You will find that you are more independent, that you want to continue and expand these habits of a healthy lifestyle. I can verify, and we can all verify, that if we value ourselves, we look after ourselves. The risk factors multiply themselves in their capacity to cause harm. For example, if you have a risk factor of 2 for having high blood pressure and a risk factor of 3 because you smoke, the result of the two together isn't 5, but rather 6. In addition to this, if you are diabetic, this will add a further 3 risk factor, and this will in turn multiply the original value. This is of the utmost importance with a very clear interpretation. We have tended to many risk factors but have completely forgotten about the risk factor of tobacco with mental health patients. Occasionally, certain regulatory laws actually discriminate against people with mental illness. One example is the current law on tobacco, which has been a step forward from the previous law that dealt with smoking areas. Inpatient units were areas where you could smoke, since it was believed that people with mental illness had a need to smoke and were incapable of stopping. The new law is a real improvement because it allows that people with mental illness can also quit smoking in the same way as the rest of the population. Of course, in combination with any required support. Around 20% of the population. This is what happens when you try to persuade people with mental illness to give up smoking, just as the general population. They reduce tobacco consumption by 20%.
It has always been said that people with mental illness suffer more with anxiety when they quit smoking than other people, but this is a misconception. People with mental illness experience the same type of anxiety when quitting smoking as those without a mental illness.
There is a myth, a misconception, if you will, along with many others that greatly stigmatize people with serious mental illness, which says, well, let them smoke. In any case, there's not much else for them to do. Let them smoke. At least there's something that they can take pleasure in. This is a huge misconception, at the very least because it impacts very negatively on their health and the most common illnesses: cardiopulmonary disease, cardiovascular disease, diabetes, high blood pressure. The country with the highest rate of smoking in the world doesn't smoke anywhere near as much as all of the mentally ill patients put together in this country. 50 to 80% of patients with schizophrenia smoke. And patients with bipolar disorder, from the data available, we can say 68% are smokers. This, combined with the other aforementioned risk factors, have devastating consequences for the health of patients with mental illness. As a group, people who have schizophrenia have 15 years less life expectancy than the general population. Another work-related error that I made was when Mrs. Carmen came with her 2 children who both have major mental disorders. Both are heavy smokers and both eat compulsively. And up until her visit, I had never thought about, and I never opened my eyes to the idea, never considered that we should work with strategies for healthy living. And I thought, with their illness, they already have enough to deal with. What I would like to get across is the privilege and responsibility held by people working in primary health care who are able to encourage the idea of giving up smoking to people with serious mental illness. However, it is important that this advice is given in a continuous and consistent manner in order to be successful over time. I believe that you have to have a very clear idea that people with mental illness have the same impulses as those without. For people without mental illness, impotence is a problem. If a person with a mental illness is starting a relationship, it is equally important to them as it is to other people. When there's a problem regarding sexuality or a desire to have a fulfilling sex life, you realize that the psychiatrist or the nurse will hear you, but they won't pay attention to you. They hear you, but they don't listen to you. They don't consider it important.
There was one particular case with a service user who was living in supportive housing provided by FAISEM, who wanted a single room because they had met someone and wanted to have a sexual relationship. We told the psychiatrist that they had met someone and wanted to start a relationship, but the psychiatrist told us how, in a flat within supportive housing, would it be possible to allow a relationship. We said that if we are to help people live life to the full, this is just one more aspect. We saw it as exciting that this person was showing an interest. They treated their partner well, they were both happy together. But what they told us was no, never inside the house. It could get us into a lot of trouble. If they had to continue the relationship, they should find a different place. How could we not acknowledge this necessity?
If you have a mental illness, you have a problem. And on top of it, if you become pregnant without wanting to be, you have 2 problems, 2 big problems. Pregnancy, whether from a preventative aspect or a successfully coming to term aspect, needs gynecologists, obstetricians, and psychiatrists, along with the parties concerned and their families, all working together. When a psychiatrist has a patient in front, they only see a mentally ill patient. It means nothing to them that she may want to be a mother. Concha was a young woman with a disorder. She was a little more than 20 years old and she had schizophrenia. One day, she brought a friend of hers into the consultation room where we were talking, and I started to suggest to her friend that maybe she should come to the family planning clinic. The second time I saw my patient Concha, she said to me, "Look, Dr. Espinosa, I was a little bit shocked." I said to her, "Why? What happened?" She said, "When my friend came, you suggested the possibility of going to the family planning clinic. But me, who you see almost every 2 months, you've never even suggested it to me." The truth is, I was stupefied. As a conclusion, it will work if we all listen to each other. The doctor must listen to the patient's problems. The patient should also listen to some concern raised by the doctor, and the professionals must listen to each other. And finally, we will all reach an understanding.
If the healthcare professional is not open to negotiation, empathy and listening, and if we don't have our eyes wide open and our ears even more so, to listen and see what the service user is saying, in the end the service user will ignore us and make their own decisions.
Mental illness forms part of our lives and part of our health, but it is just one side of us. We have many more sides as people. Often, it is not a question of making a big effort. It's a question of realizing what we have got and realizing that it is so normal and we have to do the same as everyone else. There's no difference at all. In order to improve matters, we must speak more about stigma. The professionals need to know what stigma is, and the patients need to know what stigma is.
For patients who have been so very marginalised, there must be mandatory information for health workers, not just the psychiatrist, but indeed for everyone.
Awareness courses about mental health, especially aimed at healthcare professionals, but also open to service user participation. There are professionals working in certain services, for example in A&E, who can play an important role in the fight against stigma. For example, the porters, the auxiliary staff.
The unknown causes fear.
Just because you have an illness or it's a mental illness, there's no reason for a doctor or a GP or a nurse. There's no reason for them to treat you inferior to anyone else. In fact, some of our members, when they speak with their psychiatrists or nurses or other professionals, they talk about other issues, separate from just purely eliminating the symptoms. No? Even so, these cases are fairly rare. There's a saying that we do what we have in mind, and we have in mind what we have thought and considered carefully. If we think about it and decide that this is a problem and that this is a task we have pending that must improve, or MI as we said before, then we'll have it ready. And it may very well come out just as easily as it does for other people.
The situation has drastically improved. More and more professionals from all areas of healthcare understand illness as a changeable thing, and they are confident that people with mental illness can recover.
If we compare the past to now, we can see that we have progressed immensely. I also believe that in this area we can progress a lot further.